pilot counties, 4 of them are going to require an additional 3.9 billion shillings. 3.9 billion shillings. 1.4 billion of that is from the World Bank. 2.5 billion is in our regular budget from the National Treasury. The assumption, and has been documented in an MOU between the ministry and the counties, is that the counties will continue to invest from their equitable share. You will be disturbed to note today that out of the investment that National Health Insurance Fund is making, 2/3 and sometimes 3/4 of the reimbursement is ending up in private facilities and or faith-based facilities.
Now that story actually serves as the preamble for the interview tonight, and we're going to be talking about the universal healthcare pillar of the Big Four agenda. And we have 2 gentlemen who are here to help us unpack and examine the whole program as best as we can within the limited time that we have. Today we have Dr. Rashid Aman, who is, I think, a pharmacist by training.
Yes.
And he happens to be the Chief Administrative Secretary in the Ministry of Health. And today we are also joined by Mr. Alfred Obengo, who's a gentleman who champions for the rights of nurses. You've seen him on air over a number of occasions, talking about very serious issues affecting members that he represents. And he's here to help us unpack this topic. Karibuni, gentlemen. Welcome to KBC Channel 1.
Thank you.
Yeah. So first of all, Bwana Waziri, I believe it will be in order to have you explain in the best way you possibly can about the universal healthcare pillar, the Big Four. A number of Kenyans, it's been one of the critiques, or rather one of the observations that people have made, that a lot of Kenyans on the ground have little to no knowledge of this. They know of it, the title, in the Big Four, but they're not familiar with it. Yeah. Would you care to unpack it for us?
Yeah. Thank you, Victor. I think the term universal health coverage, people know it as UHC. Its definition really from the WHO and global point of view is, in the case of Kenya, for every Kenyan to be able to receive preventive, promotive, curative, rehabilitative, and palliative care without incurring any financial distress. So the aspect of protecting citizens from financial distress is key in UHC. You know very well that healthcare, at least currently in Kenya, is fairly expensive. And you know that we have very many Kenyans who are all pushed into poverty every day because of healthcare costs. Healthcare costs either for their own healthcare or healthcare of relatives and extended family. So that's really the idea of UHC, and it's a philosophy that has been applied in many other countries that have managed to achieve UHC, is to be able to provide these services to the citizen with minimal financial outlay by the citizens themselves.
Okay.
And it can be provided in different ways. There's through an insurance system, which is risk pooling and providing services. Insurance, of course, is based on spreading risks through pooling resources. It can be provided through that. It can be provided through a tax base. And in many countries, it is indeed provided through a tax-based.
What is the model which Kenya is going to use?
It is still going to be an social insurance-based model, but it will be supported through a tax base where we shall be investing, the national government shall be investing alongside the counties will be investing in bringing up and improving the health services and facilities that we offer in this country.
All right.
Now, what I want to say also is that the key element of UHC also is that healthcare must first of all be accessible. Mm-hmm. Access to healthcare is important. There are many people who don't have access to healthcare, not only in the sense of geographically, mm-hmm. but also in the sense of other barriers that might stand in their way. Mm-hmm. Affordability. Affordability could be a barrier to access. So you must have access. The healthcare must be affordable. Mm-hmm. It must be of high quality, mm-hmm. and it must be equitable. Equity is important, so that nobody is left behind.
And I like that you've mentioned those aspects. We would like to get into them into a lot more detail as we progress in the course of the conversation. But at this point, I would like to bring you, sir, why don't you tell us about the response of the people you represent and your organization when this idea was first floated. I believe it was in the Jamhuri Day speech of 2017 when the president first captured all these issues under the Big Four. And we first knew about the pillar of universal healthcare. What has been your reception from late last year till present?
Thank you so much first for the invitation. From the outset, I would wish to first thank His Excellency the President, Uhuru Kenyatta, for the first time in the Kenyan history of political government. His government identified health as a key component into far as his development agenda is concerned. Mm-hmm. So on that issue, we thank the President for that, because with a healthy nation actually is a growing nation. Mm-hmm. Secondly, I want to say that as nurses, this idea could not have come at a better time than this, because we're also celebrating what is a concept called Nursing Now. Mm-hmm. Globally. Mm-hmm. It's a global movement that is just about highlighting and enhancing the profile of nurses in this world. And one of the key components and ideology in Nursing Now is universal health coverage. So we believe that all citizens and all citizens of this world must be able to access health wherever they are and whichever condition they are suffering from. So we as nurses, we are champions of universal health coverage, both locally and globally, because the more the citizens access health, also the better for us. And in the process, we are also able to showcase our intellectual prowess and professional input that we give into healthcare.
Right.
Yes.
I believe you just had a conference recently. Was it in Kisumu?
In Machakos.
Machakos, I mean,
yes.
Yeah. Right, right. Interesting note, good people of Kenya, is that one of your global members, the global members of your association, to put it very loosely, yes. Recently received quite high praise for an action that he did. A gentleman by the name of Alan Pierce in California. You understand the state of California is currently suffering from deadly fires. He drove his pickup truck out of the road through the flames and was able to rescue quite a number of people. And of course his car was melted, but because of his effort, a number of people who were suffering from the fire were rescued. I just thought it would be good to mention, nurses are doing great things across the world.
That shows you how committed and dedicated we are to our work. But most of the time, I will say when Dr. Rashid is there, that we are not appreciated. Right. But we go out of our way to ensure that we save lives. And that's our core duty.
We'll come to that in a second. But first of all, we're not really first, but as we proceed with the rest of the conversation, the information out there is that this program is going to be rolled out in certain select counties on a trial basis, kind of like a pilot basis. Yeah. Can you be able to give us a bit of information about that?
Certainly. Victor, first of all, I think we are at a very momentous time right now because His Excellency the President has has pronounced universal health coverage, attainment of universal health coverage as one of his legacy agendas. Therefore, I mean, the political goodwill that we enjoy right now is tremendous, and I think we can ride on that to ensure that UHC is a success. The approach towards UHC is going to be two-phased. The first phase is going to be a pilot, or so to call maybe a test run, and we are going to focus on 4 counties. These are the counties of Kisumu, Nyeri, Isiolo, and Machakos. And we shall be rolling out the model of UHC that we have now agreed upon in those 4 counties. Why? The reason, why do we want to do that? It's an undertaking, and a serious undertaking to achieve UHC. And I think it's appropriate to test the model that you want to apply. You know that in science, you always carry out a pilot before you scale it up.
Right.
So it is really that thinking that we need to be able to test this out in a few selected counties, and we can then observe how we are performing through our very careful monitoring and evaluation system, and pick up the lessons that we can learn.
Now, Kenya is a very broad country, and health is, in matters health, the challenges faced by different regions vary. You know, there's a vast array of issues. Could you please tell us what sort of criteria went into the choosing of those specific counties of Kisumu, Isiolo, Nyeri, and Machakos, and what, if at all, that criteria is expected to influence, or what kind of information is expected to be gathered from there, and what sort of representation are you looking at there?
Exactly, and I was actually coming to that.
Right.
We have a large country. We have a varied geography and topography, as well as disease burden in different parts of the country. The essence of the pilot will be to try to understand the challenges that we may face across this varied landscape. Therefore, the criteria that we chose to be able to pick this for is to look at the particular disease burden that may occur in certain regions. Kisumu was chosen because it has a high burden of infectious diseases. Malaria is a big killer. We have HIV and TB. Those are the major infectious diseases that we deal with in this country.
Or in the country as well?
In the country generally. Right. But that burden is higher in areas around, in Western Kenya.
Right,
around the lake area, yes. Right. So Kisumu was chosen to represent that area that has that type of a disease burden.
Right.
And indeed, infectious disease is probably number 1 on the list of killers in this country. The second we chose is Machakos. Now, Machakos was chosen because, as you know, Machakos, it lies on a very important northern corridor highway, and we have a lot of accidents and trauma cases. In fact, accidents and trauma are number 2 killer. Wow. So it actually represents for us a look at that disease burden.
And it's interesting you should say that. Waziri Kariuki, a few days ago, she was in Nyeri, and she was talking about some of the issues you're talking about. She mentioned that she does support very fully, and her ministry indeed, the crackdown on Matatu, because she said, about I think I believe the figure was about 10% of the cases in that hospital that she visited. Well, as a result of accidents and such.
Number two.
And then she felt if those funds would be directed to other well-deserving causes.
So that's where Machakos comes into the pilots.
Interesting.
Nyeri comes into the pilots because Nyeri has a very interesting disease burden. Nyeri has a very high burden of non-communicable diseases, especially diabetes.
Is that so?
Yes. The incidence of diabetes in Nyeri County is fairly high, very high, unusual. In fact, for a county which is largely, to a large extent, rural type of farming community.
Right.
And as you know very well, non-communicable diseases, or so-called lifestyle diseases, are there because of lifestyles. So it's a unique case that we want to look at in the pilot as well and see, you know, what kind of issues will arise from this. Finally, Isiolo represents our frontier districts, where we again have a very unique, different situation from the rest of the country. Most of those counties out there are vast in semi-arid areas, pastoral lifestyles, people moving, and the challenges that you know, delivery of health services faces in those areas with the sparse population, probably very fast-paced facilities and so on. So you can see that when you look at those 4 counties that we have chosen, we really expect to get a good picture of what's happening within Kenya and be able to learn lessons. So I said earlier on that we will be approaching UHC through 2 phases. This first phase, which is going to be launched by His Excellency President Uhuru Kenyatta in
early next month.
Early next month, in the first week probably, maybe, is the pilot test. We intend to run the pilot for about a year at most. But it is very likely that within 6 months or so of running the pilot in the 4 counties, we may be in a position where we have gathered enough information and lessons to be able now to scale up. So the second phase will be scaling up to the other 43 counties.
Would that happen simultaneously, or would that
it will probably happen through you know, an ongoing phased approach where you'll bring on board counties as we move along.
What sort of timelines are we talking about
for us
to be able to achieve
I think
countrywide coverage?
Well, you see, we're also moving towards trying to get to a point in 2022 where we can say this is where we are with UHC. So it's important that the scale-up is done within as short a time as possible.
All right. I would like you to jump in on it just before you continue. I'd like you to jump in on this. And what are your views on the approach taken by the ministry in terms of scaling up this operation?
We are pleased with the process that Mr. has undertaken. We've been involved in various stages of the planning, of which we still want to be involved more on the strategic areas. And one thing that I will wish also to point out so much is that UHC is built upon 3 pillars, which I will wish to add a 4th pillar. The first pillar is accessibility. The second pillar is quality. And third pillar is about the financial sustainability, where down the insurance comes in. But we as the healthcare providers, we feel like the provider has not been given that serious platform. But we are in negotiation with the Minister of Health so that we can have that, because when you talk about UHC, it's not just about the card, but there's also the drug that you have to get in the hospital, and who is going to give you that drug. There's also that service that is going to be given. So this service provider must also be given that priority insofar as the planning is concerned.
It's interesting you should bring that up, because a number of concerns have been raised by some members of the public and some stakeholders such as yourself, and a number of observers and researchers. If I may be able to quote a paper published in the Global Journal of Health Services, volume 8 of 2016, by 2 gentlemen, one from the University of Nairobi, I believe is a gentleman by the name of Okech, and no, he's from USIU, and another one from the University of Nairobi, I believe his name is Ntumbesi. And the concerns that they have are that there are certain gaps in the sector, gaps in policy, gaps in capacity and skills, gaps in financing, gaps in ease of access, gaps in products and equipment, gaps in implementation, and a wide range of gaps. I'd like to narrow down to something that you mentioned just now in your response, and perhaps you can shed some light into this, the skills and capacity of your people, the people you represent, in being able to actually midwife or being able to deliver this very ambitious project. There are concerns that there are gaps in skills and in staffing as well. What have you got to say about this?
First of all, I would say that in any new concept, any new program, any new project that the government or any other authority will come with, definitely there will be challenges. But these challenges are not insurmountable, and they will not actually prevent us from pushing the matter forward. What is important is for us to work together to address these challenges. It's rather obvious that insofar as human resource capacity, we still have gaps here and there, so far as the competencies, skills, capacity, and most importantly also the quantity of health workers. I mean, we have a serious shortage of nurses, doctors, and all other health personnel. And that is why, from our point of view, as we support the UHC, we believe that the government will also be able to, both the national and the county government, to address some of these gaps. Because when you say that the citizens of Kenya will come to the hospital and get that kind of service free of charge, definitely you expect an increase of work overload. So
and indeed, the 4 counties that have been chosen for the pilot program, we're talking about Kisumu, which has a high population density. We're talking about Nyeri, equally, a very high population density. Isiolo and Machakos represent a very interesting dynamic, I believe. Could be wrong, but I believe the terrain and the kind of the experience, the area there is not very friendly for. In fact, I'm aware that a number of health workers who work for government organizations prefer not to be posted in such areas, you know, the so-called hardship areas. So how do you see that, maybe I should rephrase, have you and your organization and people you work with, the health service providers that you represent, have you been consulted in the process of rolling out the pilot program in terms of also perhaps piloting or testing or experimenting with some staffing ratios that would be able to help this program run properly in the 4 counties that the pilot is being unveiled in?
On that technical aspect, I will say that the last meeting that we had with the Cabinet Secretary, insofar as we are just sharing ideas on how we are going to participate and also influence the implementation matrix in the 4 counties and also all over the country nationally. There was a commitment from the CS that we are going to be engaged so that we address these challenges together.
In what capacity would you say?
Both at the county level and the national level, and there are those committees that also have been formed addressing different issues and at different levels.
And what some of the recommendations?
Definitely our engagement is that's what I've just told you, that one thing that is component that is very important is that we must enhance and increase the staffing ratios of the nurses and the doctors and the clinical officers. And 2, we must also, as you ably said, that some of our health workers who wish to work in those hardship areas, we must also address the issue of developing incentives to attract more health workers to work in and nurses to work in those hardship areas. And one of those incentives actually is just an issue of addressing some of the simple issues that and agreements that we've done with the national and county government. There's some issues based on promises that were given which have not been addressed, and we hope they're going to be addressed. When we, you know, last year what happened was very, very unfortunate, and we wouldn't wish to go there. And we made a promise to the Minister of Health, the Cabinet Secretary, that we want to engage in dialogue so that we don't go back to where we were last year. And you know, that really affected the health service delivery. So we wish that these issues be ironed out. There's a specific issue that I must talk about on the issue of a return to work formula that was agreed between the nurses and the national county government. Let it be ironed out, because we don't want to look at this as an impediment to the UHC implementation.
Very good that you should bring that up, because now the gentleman from the ministry is right here and he can be able to address some of these things. So what contribution would you have to some of the issues that Mr. Obengo has raised? And by the way, matters, labor, are a powder keg. It is a ticking time bomb in any sort of industry, especially one that is undertaking such a noble but ambitious project. You need all hands on deck. What are some of your views on this?
I want to step back a little bit and maybe just talk a little bit about what it takes to have a very well-oiled operating health system.
Yeah.
The building blocks, they are key building blocks for any health system. Human resources for health is a very important one. Leadership and governance is another one. Financial management is another one. Information systems, health information systems that inform you in making decisions is critical. The commodities, whether it is equipment or drugs, is very important. And service delivery, which is provided by the human resources for health, very critical. Those are only some that come to mind. But let's now come back to number one. In our Constitution is enshrined the right to the highest standard of health. Therefore, quality is very important. And as we move into UHC, all of these elements, all of these systems have been looked at and will continue to be looked at and will be strengthened. All that. Now, if we come back to human resources for health, human resources for health, you asked a question to Mr. Obengo whether there was consultation with the health cadres in planning for UHC. There has been quite a bit of consultation because in preparing for these 4 pilot counties, a lot of work has gone in to see where the gaps are in all of these systems, whether it is human resources, whether it is commodities, whether it is equipment. Because once you roll out UHC and you say you want to provide quality, affordable, accessible, equitable services, you have to be ready for that. So assessments have been carried out in the 4 pilot counties, as well as in all the other counties. The gaps have been identified. As far as human resources for health is concerned, the ministry has looked at what the ideal optimum ratios as defined by the World Health Organization is. And we fall far off from the ideal ratio. That's a fact. We have gaps. We cannot deny that we don't have gaps in our entire health system. We do have. But how do we now begin to close this gap? So those assessments have arrived at some figures and have built into the preparations for the pilots how to improve that. So as far as HRH is concerned, there is a certain level of build-up. We're going to see more, all cadres who are involved in health service delivery will be improved in these 4 counties. Okay? And it's not going to stop there. Of course, we'll have to try to move towards the optimum. There are challenges. The other challenge, as far as HRH is concerned, and Mr. Obengo will agree with me, is that we have to realize that we are now in a devolved system of government. Health is one of the functions that has been totally devolved to the counties. So really, service delivery, employment of human resource is a function of the counties. As a national government, we work with the counties to provide the guidance, to provide the policies, to provide the coordination, technical capacity building, and mobilization of resources. But we work together, and we have to work very closely together in order to ensure that we are able to address these gaps and try to bridge these gaps as we move towards UHC.
Right, and at this point I would like to introduce another subject, and this is a concern by some of the members of the public that we spoke to earlier in preparation for this. And their questions, there's a bit of lack of clarity to them about exactly what the scope of the program is going to be in terms of the benefits involved. And NHIF is a big part of this. And some of the questions, and in fact, if I may pull up one of the quotes from Madam Waziri, it was roughly to the tune that when you roll out, you're not going to be able to cover every single thing, every single ailment, every single aspect, and it's going to be piecemeal as time goes by. a lot, judging by the hype and a lot of the expectation that is in the eyes of the public, there's a serious issue of perhaps a clash of perception versus reality kind of situation coming up, because a number of people are expecting so many things, yet the rollout is going to be piecemeal. What would you be able to contribute to this sort of
and I think that is important, Victor, because that is where also you need to be able to temper the expectations of the public. And that's bound to happen in any program of this nature, because you will have different players who will have their different interpretations of it. As a ministry, we are approaching this problem, this issue very carefully in terms of the messaging and the communication that will be going out to the public. And it has to be communication that will portray what they should expect really when they go to access these services within the facilities. The CS appointed a panel of experts to work out a basic minimum package of services that could be provided in UHC. The panel has completed the work and has defined the package, what the elements of the package is.
Can you give us some
That's
details?
a starting point for us. But now as we move into UHC, what we can say that the public will receive within the facilities in the 4 pilot counties will be, number one, they will be able to receive services at the community level. These would include all the public health, public environment services, which as a Ministry of Health or the counties routinely conduct.
Such as cleaning
such as
drainage,
preventing insect-borne diseases, taking control of the environment, draining water, cutting bushes, indoor spraying to prevent mosquitoes and other vectors of disease. Then there will be the community services, and community services are going to be one of the key foundations that we want to build on, because the community service or community strategy that the ministry has developed over the years is going to provide that interface with the community. So health will now be moving proactively into the community through deployment of community health workers and community volunteers who will be trained. A whole army of community health volunteers will be trained. They will be trained by community health extension workers and nurses, and then they will be equipped with some basic level of equipment to take vital measurements and provide whatever necessary treatments that they can at that level, but they will be interacting with the community. Those community services will include providing information to the community, raising awareness, doing some simple screenings, being able to refer patients to first level facilities, so on.
All right.
And then we have the primary levels of care, which is 1 and 2. In primary level of care, you provide care to especially mothers and children, child health and mother health, where you're going to provide vaccinations, you're going to provide care for pregnant women, antenatal care, and ensure that they get skilled delivery and all that. These are critical because these are the things that, and also provide health promotion and information, knowledge, sensitize people. You advise them and teach them on how to maintain a healthy life. The emphasis on primary health care is key. Experience has shown that for UHC to succeed, you really need to put a lot of effort in that area. Why? Because if you do that well, and you're able to do that well, you will be able to contain, you'll be able to detect, first of all, conditions very early. You'll be able to prevent effectively, and you will have, you'll reduce the number of people who actually present at a later stage with an advanced disease.
I see.
And then the referral system is another key thing. We need to build a very strong referral system so that we have, when we have good services at all those levels, and people go to 6D services, they will be able to be taken care of at those levels. And they don't have to, constrain the referral system by going for services which they can obtain at those levels to Kenyatta National Hospital or a level 5 hospital.
Right.
So really that's what we're looking at. Okay. And we hope if we get all these pieces together, all of us who are involved in the health sector, that we have a chance to achieve.
All right. Mr. Obengo, information is power. King, indeed. Do you believe that this concept has been properly communicated to the public?
My take on that and my approach towards universal health coverage, I look at it as a journey. And a journey of 1,000 miles, or 1,000,000 miles, always begins with one step. As you've indicated clearly, probably there may have been some gaps insofar as the communications are there, but what you're saying that if we are ready to work together through these challenges, then we are going to handle them together with the Waziri and other authorities. One thing that we're also very keen on as nurses and as the health care, when you look at the universal health coverage, is that as we move forward, we also have some issues that we may need to address, including legislation, so that we prepare a good background and platform so that to implement the UHC. And legislation involves issues also to do with practice. Like, as you know, as of now, as Waziri has said, that when you talk about community health workers, extension workers, we are talking about preventive medicine. And that takes us to the non-communicable diseases, that is NCDs, hypertension and diabetes. These are diseases that if we handle them at the community level through health education, as you say, information, you even cut the cost of healthcare in terms of curative services is concerned. But now who does that, community health worker? You find that at the basic level, the lowest level of any health institution, you'll always get someone called a nurse. So the nurse is the link between the community and Waziri. So and at that level, the nurse is practicing in the spectrum of her practice. She's doing some duties which are not anchored in law.
I see.
And those are that's why we bring up the issue of
yes,
I bring the issue of the legislation.
Right.
Because if she's performing duties that are not anchored in law, it means that if push comes to shove, she's left on her own. So these are the issues that we would wish to address with Bwana Waziri Daktari, so that we move on, we have a harmonious environment where all of us can implement the UHC. Because as we are speaking now, the nurse is at the community level, is the doctor, is the pharmacist, is the laboratory. You know that. It's everything. But that is not anchored in the law. So these are the things that we will use to move the conversation further so that we handle some of these issues.
Right. And speaking of that, my director informs me that we are dangerously low on time. As a matter of fact, he's advised me to wrap up right at this minute. But if I may beg his indulgence for just 2 minutes as we kind of bring this matter to a place. Like you said earlier, this is a journey. This subject is so big that it's going to be rolled out in a pilot program for 4 counties and then slowly upscaled for the rest of the country. And therefore, it only stands to reason that such a conversation would also be held in stages. We may not be able to cover all the aspects all at once, but there's some people, 4 personalities who have spoken about this, and I'd like to throw out some quotes, and as briefly as you possibly can, I need both of your comments on this, right? First of all is, the first one was your Waziri, and you've been able to capture that, thank you very much. Dr. Githinji Gitahi, the CEO of Ambrus, has been quoted to say that when we under-allocate resources to health services, we continue to delay economic development because health costs impoverish people. And then he further said that the country's current budgetary allocation to healthcare is way below the Abuja declaration of 15%. Gentlemen, what have you got to say about that, as briefly as you possibly can?
That's very true. Everything that we talk about is going to require resources, and tremendous resources and goodwill to go along with it. Indeed, we are below the 15% of budget declaration. I think our current budget stands at about around between 7 and 9%. So we have a long journey to go. But the political goodwill that we have, the all of it, of course, depends upon the growth of our economy. I think we will be able to edge again towards that. That's another gap. So we have many gaps.
Many gaps.
But we're going to move towards
but there is hope.
Closing these gaps. There is hope.
Fantastic.
Yeah.
Mr. Obengo?
The Abuja declaration is more or less also related to other Almata declaration about primary health care and meeting the community needs, eradicating poverty. That still comes to the issue of resources. But I'm happy that Bwana Waziri has committed himself, and most importantly, the President of the Republic of Kenya himself has the goodwill, the political goodwill is there. So we're going to take advantage of that and see how we can move this conversation further.
All right, next to last, Professor Kivutha Kibwana, one of the early adopters of the UHC at the county level. He said that during a public participation process in his county, it emerged that the biggest challenge was access to health services. And indeed, you mentioned it earlier. What thoughts have you got, as briefly as you can? Let's start with you. Access.
Access is very broad. You can write a